Hi everyone, and welcome to episode 15 of The Only Way is Ethics. We have with us today Dr. Saif Abed. Welcome, Saif, to us. Thank you ever so much for taking your time to join us on the podcast. For those that have seen the podcast before and know the format, we'll hand over to you to give us your journey into digital health and information and cybersecurity, how you got into the space. I know sort of you've got your clinical background as well, so it'd be interesting to hear about that. And then we'll start. We've got lots to discuss, and there's lots of topics that we'll I'm sure the audience will be really interested in. So I'll hand over to you.
Thanks, Dean. I've been looking forward to this. I'm sure we're gonna get through a lot, and it's going to be really interesting. In terms of my journey, it's quite interesting that you ask. It was just this weekend that we went back to Cambridge with my family to show my daughter kind of where it all began, and it's been just over 12 years, and it's just surprising how time flies. You don't even realize it. But so I went to med school at St. George's Hospital in London.
Okay. Yeah, Tooting.
Yeah, sunny Tooting. And while I was there, that's when the National Program for IT, shall we say, was starting to encounter some issues. And as someone who was interested in both the worlds of technology and business and how they kind of vaguely intersect with healthcare, it was something I was quite keenly aware of. And that's when the person who would end up being my business partner, who's the year above me, we said, okay, let's graduate, let's practice medicine for a few years, and then let's kind of go to business school, but use business school as a cover to try and create our own business, whatever that's going to look like. There wasn't really a clear plan. The initial plan was, we both went to business school and I was at Cambridge, was that maybe, just maybe, some of these big tech companies and governments might want to listen to clinicians when they implement technology. Because I don't know, it didn't seem like it's worked out over the last, the previous, 5 to 7 years. And that's what we were thinking around 2012. So that's when I set up the AbedGraham Group. And really, there was not a clear plan in terms of what we're going to do beyond that thesis of we need more clinician engagement. And that's when we started, focusing on benefits realization, really understanding, working with NHS trusts and vendors to understand what are the actual benefits to clinicians of these technologies, getting them to understand how clinical workflows affect nurses, doctors, physios, radiotherapists, pharmacists, anyone you think of. But what became really interesting early on is that I, in particular, was interested in risk. I was interested in the negative side of things. And at that time, it was more about what happens if the technology is misconfigured or not implemented in the right way, or it's misused. I wasn't thinking in terms of malicious activities just yet. But as you can imagine, it's not a big leap to start thinking, well, what if someone tries to break this on purpose? And I started writing articles on LinkedIn about this, and I started seeing cyber attacks, mainly data breaches, happening in the United States. And I thought, well, things tend to migrate over in terms of trends from the US over here, slowly but surely. So I thought, well, the next level isn't going to be data breach. It's going to be this thing called ransomware. So I wrote an article where I listed 5 different types of technologies you find in a trust: EHR, e-prescribing, hacks, laboratory information systems. I just said, what would happen if you lost access to each and every one of these in a trust? I wrote this article, and we weren't really doing big work in cybersecurity at that point. It was still very much information risk. We're doing work, a ton of work on DCP 129, all that stuff. But a year later, WannaCry happened.
Right.
And everything changed. And it's at that point that people started saying, did anyone know this would happen? And a few people stumbled on my article going, well, some people have been talking about this, clearly. And then from there, we really started becoming both a clinical safety consultancy, but very much a cybersecurity consultancy. I did another master's degree that after that. I did one in cybersecurity at Oxford, where I did the GCHQ pathway in particular, just to give you a sense of, how deep I wanted to get into this. And then from there, we won one of the first contracts with IBM, with NHS Digital, to help evolve the Cybersecurity Operations Center. I started advising the European Commission as an expert. And then through at the beginning, getting into COVID, I and the AbedGraham Group got appointed as one of the most senior experts on cyber for the World Health Organization. We've been working with them ever since then. And that work also covers chemical and biological and radionuclear, as well as healthcare. So it's been this really interesting journey, lots of education, lots of public speaking, lots of getting to know people in the sector. We work in intelligence now. It's been a wild journey. I could keep going, but I hope that gives you a sense of where I started and where I am today.
No, absolutely, and thank you for that, Saif. And I think it's like, it's great because you've gone from sort of like, this journey from the like you say, that clinical side, and then through and being quite prolific within sort of like information and cybersecurity. You've written a number of papers in relation to that, and it's interesting also that AbedGraham Group, obviously you do sort of like the clinical safety side of it as well. I know you say you're not predominantly focused on that. That's your partner, etc., and stuff like that within the group. And I'd like to kick this off in relation to sort of like our discussion and what we're talking about. So DCB 129 and 160 clearly sort of like state, yes, there is sort of, they say there's some sort of crossover with information security, but it's very loose in its sort of like in its meaning, and it's almost like saying that don't worry about the information security bit, someone else is dealing with that. This is all about clinical safety, and that's fine. But I think from my experience, and I will hold my hand up here and say, in my 18 years of doing this, is that there's not a lot of attention by clinical safety officers in relation to information security. The majority of them, and they will pay lip service to it in relation to that. So it'd be good to get your views, because obviously you've got a hell of a lot of experience, and I know you put it out there quite a lot on LinkedIn around sort of that whole patient safety, information security piece. So, what are your views, and what can you sort of like, impart to the audience around that?
Yeah. First of all, cybersecurity is patient safety. There is no way around that. I've been using that phrase for years. It's even been a phrase that's used now in the United States officially in some government circles, a slight variation of it. When looking at clinical safety, you have to consider, if you have a technology, it can go wrong, and it can go wrong either by accident or due to malicious reasons. And if you're developing a risk register, you have to, as a part of that, assess what are going to be the sources of disruption. And if it's by accident, you have to be aware it could be a one-time thing. It may require a certain fix. It can be addressed in a certain way. But if someone wants to break your system, break your product, break a workflow, and they're doing it because they want money, then that's a different type of threat to your system and clinical safety. They're going to be more persistent. They're going to be more advanced. They're going to, once you put up one defense, they might bypass that because they want to make sure you are unable to use the product or system to force you to pay a ransom. And that is a completely different ballgame. You cannot be, I would suggest, prepared to preserve patient safety if you're not aware of the sources of risk and how to mitigate against them. Now, to be fair then to clinical safety officers, obviously we've got a bunch of CSOs in our team who work with companies and whatnot. This is not easy, because it's one thing to have a deep clinical background and understand clinical workflows and the implementation of technology. But to have an expertise in cybersecurity, that's its own industry, its own training, its own certifications. I've got a master's degree in the subject. That's how far I wanted to take it. So it is a little bit, I want to be fair and say, it can be unfair to say to a CSO, oh, why are you only paying lip service to this? But at the same time, then whose responsibility is it? I would say it's whoever is going to be the entity that trains CSOs, that sets the standards, that sets the guidance, that sets the requirements, that should state, actually, cybersecurity is a major component, if not a 50-50 component within this standard. And this is how we recommend you address it. Here is a framework. Here's some guidance. Here is a template, even that at least make sure you cover your baselines. If we don't do it though, which, as you raised there, it's done in a very light fashion, if at all. Are you actually doing clinical safety if you're not addressing cybersecurity? And I would argue that if you end up in a court of law, you would be in a very difficult position to defend yourself if you said, we did clinical safety for a technology, but we did not address cybersecurity.
Yeah, no, you're absolutely right. And if we take that one step further, and thank you for those insights. And I mean, if we look at the NHS and NHS England and the whole governance policy and resource allocation in relation to cybersecurity, you'll know more than I will. Is it enough? Now, in what I'm looking at is in relation to, should there be, you say cybersecurity is totally patient safety, and I completely get it. Therefore, should we be seeing sort of cybersecurity experts within the digital clinical safety team? That would make sense, or at least that they've got sort of access to those guys. Because I don't really see, for all my training, all my updates, etc., it's never on there. Cybersecurity, information security, it's never on there. And you say about it should be in the training, etc. It should be on syllabus, shouldn't it, in relation to that? And we should be more aware. We have, I know as clinicians, and you've probably done sort of the mandated training that we do, etc. And people, again, don't they? And I know from me, it's tick through all the things, tick the boxes and all that. Oh, you passed 90%, and that's it. And then you get on with your day job. There's no, I think there's sort of little or nothing in relation to the implications and the impact is there in relation to that. I think that's what we should be doing more of and should be concentrating on.
So I'll take it in stages. Whenever I've worked with NHS Digital, previously NHS England, and I've worked with the cybersecurity teams and leadership, they have wanted to know more about the clinical safety standards. They've wanted to try and understand those and their significance. But ultimately, they are two separate departments. They are not tied together, and I, at least historically, have not seen them dovetail in their activities the way one would want. So that in and of itself is a challenge, because you have one part of the house that's tackling the issues of cybersecurity, standards, enforcement, support services. But that's just for cybersecurity. And you have another that's attempting to do it for clinical safety. And that it's like with everything in healthcare and the NHS, you end up with a siloed structure, and we all know the issues with that. The big problem for me goes beyond even that, though. I think we have, and I've said this, I get on really well with everyone on the cyber side from NHS England. So I've been on panels with them and I've said exactly this, so they know my viewpoints. The NHS supply chain is completely broken, as far as I'm concerned. Okay. There is minimal oversight, minimal enforcement, no penalties. No vendor is scared of not being seen to implement cybersecurity standards or DCB 0129, not fully or at all. There's no fear there. The only time there is concern is when it's a barrier to procurement. And we've seen that a bit with DCB 0129, at least in the past few years. But for me, unless we're willing to have regular audits, mandatory regulations, penalties like blocking vendors from accessing the market if they're not showing compliance, or meeting a standard post audit, if they're not willing to have a strong regulator who's going to do that, then the subject that you and I are talking about right now is kind of going nowhere, because you and I can academically agree that DCB 0129 or 0160 or the job role or service role of a CSO should have this level of cybersecurity requirement or expertise within it.
Yeah.
But unless you have a strong regulator who's willing to police all of this, it's not going anywhere. So for me, that's the bigger fundamental issue in terms of the state of patient safety and technology in the NHS.
That's an interesting point, and we've not stumbled across it, but you put it out there, and it's really passionate of mine as well. Let's pick that point up. So we're talking about, where is that regulation, where is that governance in relation to our standards? Now, some people may argue and come back and say, okay, so we introduce penalties, we introduce fines, or if you say with vendors, taking their products off the market, that becomes more difficult in digital health, because if you're an incumbent and system within a health organisation, if you were to rip that out, you'd probably cause more risk than you would sort of like reduce risk in relation to that. Because as we know, sort of like, it holds X amount of patient records, or it supports X amount of workflow, etc., especially if it was an EPR and that was seen to be sort of like, unregulated. And then also you've got the likes of MHRA, who've already said they don't want to touch 0129, because there was talks around trying to align it with 14971 in relation to risk management. So we've got all of these sort of like, me and you know that it needs to be better regulated. There is no doubt that it needs to. But when you've got the likes also of AbedGraham, ABHI, and these independent associations and bodies that are producing their own white papers and their own sort of documentation saying that the DCBs need to go away, the role of the clinical safety officer, what's the point, etc., and stuff like that. At the moment, we are in flux, aren't we? We're in sort of, and then if you add on top of that as well, Saif, that we've got the consultation now coming up that we know of DCB 0129 and 160, and of DTAC as well, which we know as a framework is a good idea. However, it's been implemented really poorly in relation to that, so it needs to change. So where do we go in relation to that?
Just to answer your first question, you wouldn't rip out a technology, but you can say to a vendor, you can't sell any more within the market until you address X, Y, and Z. So I think anyone who says that is that's a straw man argument. So that doesn't go. So that's number one. Number two, well, I'm going to address your third point. I have no interest in the views of any think tanks or bodies. They're there for the interests of their members, and the members for any. Look, let's be clear. 90% of my work is with the private sector. That's why I can speak truth to power on it. I have no agenda here. So, think tank is going to think tank, trade body is going to trade body. And that means if they could have zero regulations, that's what they want. But they can't just come out and say that. So I ignore anything that's said by any trade body. What I don't ignore is articles written by investigative journalists that show an association between patient morbidity and mortality and the implementation of EPRs in the NHS. I don't ignore when a coroner reaches a similar conclusion. I don't ignore when a cyber attack leads to ambulance diversions and delayed chemotherapy and delayed major life-changing operations. I don't ignore any of that. And I think if a consultation happens, or the consultation that's happening, my view is it's to strengthen the implementation of the standard, or at the very least, to maybe alter some of the guidance associated with the standard. Because I don't think you can do away with patient safety or clinical safety standards. I don't think, as much as anyone, look, when you work in cybersecurity, everyone likes to beat on government agencies. And I have to say, governments are always slow, but I found the people that I've engaged with to always want to push things in the right direction. Whether they're actually able to because of the bureaucracy is something else. I don't think anyone wants to remove standards to do with patient safety, because just think of the optics of it. And think about when things go wrong, this is going to appear in a newspaper. And that's going to be someone's going to be a scapegoat for things that go wrong like that. But let's be clear, I've also seen the worst end of this. I mean, through the AbedGraham Group, I can't talk about it in public. I've been involved in legal cases where the worst possible outcomes imaginable clinically are what are alleged in those legal cases. I'll leave the rest to you. You know what I mean.
Yeah, absolutely.
So
absolutely.
I don't think that can be ignored. For me, it is actually quite straightforward, because we have regulations in other sectors and in the EU where we are kind of starting to do this. So look, it's very clear. We have a standard. Let's use DCB 029. We have a standard. We can improve and augment it to do with cybersecurity, but let's just say we have the standard today. It is mandatory. We now need to have someone who is the regulator who actually makes it clear that this is mandatory, and to do business in the NHS, you have to go in a database. Name of your company, who your CSO is, and upon request, we are going to audit a random sample per year. Or we're going to, look, they could appoint Dean Mawson or whoever else. We're going to appoint some auditors to audit a random sample every year. You may get caught up in that. You may not. If you don't want to be compliant, or you only want to be compliant in name alone, then, okay, that's your risk to take. But if one of our auditors turns up, there are now going to be consequences. If you're not actually compliant, here are the consequences. It's like putting a trust in special measures. We are going to put you as a vendor in special measures. And that means not allowed to sell until your documentation is addressed, which could take 1 week. It could be a 1 week exercise. Or it may be a 6 month to 1 year exercise. Depends how, shall we say, I'm going to use this phrase inappropriately, how naughty you've been as a vendor around compliance. If the second time around, let's say a year later, we do an audit again of you because you were under special measures, and you still don't have everything in place, not only are you barred from selling to further, we're actually going to fine you. There is going to be a fine. It might be just a tiny fine, but that signals intent. And you do it that way, and then that will change behaviors, because I can tell you so many examples of use cases in other industries where everyone talks a good game from a vendor perspective, but ultimately the profit motive is what counts. The shareholder motive is what counts, and that trumps everything. No pun intended there, given what's happened in the last 24 hours. but you change behavior through regulation, and there has to be a stick that comes along with the carrot. Now, the one thing I'll just add, because you've got me ranting here a little bit. If you are a company that is doing everything correctly, you should have streamlined procurement. You should be promoted. You should be highlighted. We, as a regulator, and everyone, we should be saying, these are the companies you want to work with. Here is a framework of companies that we want to highlight in particular, where you get expedited procurement because they tick all the appropriate boxes and do it consistently post-audit. So, yeah, I want to be nice to every vendor who's doing it right, but I want to be really harsh on those who are deliberately avoiding compliance, which is patient safety related.
Yeah, no, and I completely agree with you. And in relation to that, I think we can take it sort of one step further. I mean, you talk about, well, first and foremost, we've got to strengthen the standards. I think you're absolutely right. Getting rid of them, that's not going to happen. I'd fall off my chair if that's, if that ever happened. It's not. Clinical safety officers, these independent bodies saying, oh, they need to go away. And I think one of the arguments is, they don't appear in the medical device regulation or in 14971.
Sorry to interrupt, Dean. So just on that point, this is a point I'd welcome your view, but it's your interview, but I'd welcome your viewpoint as well. It's, so it's one thing for companies that are not medical devices and the role of the CSO. I personally think that if anything, we should professionalize the role of the CSO further, and we should actually make it stricter to be a CSO, is my view. But this medical device realm, that's its own thing, which if you are, you have a, CE mark, UKCA mark, you're following medical device regulations, then I could see a world where, okay, you have a strict regulation you need to follow anyway. Medical device companies, that's your own world. But where there's a gray area is that software as a medical device. And I think as soon as you are software as a medical device, my view is you should be both medical device regulation and DCB 129. And I'm happy to debate that with anyone all day long, and I'm sure I'll come out the winner.
Yeah, no, absolutely. And I think I would as well, because I think what it is, I think a lot of it, Saif, is a lack of awareness by some of these organisations where they were medical device organisations. Some of them have sort of crept into that software as a medical device. And where they're so blinkered in this sort of pathway, and all of a sudden you see this DCB 129, and they're like, what is this? It's like sort of most of it is in relation to, I would argue the point that 129 in its approach for risk assessment is more holistic, whereas 14971 is very logical and linear, and it just follows a path, switch said light on, light goes green, light doesn't go green, that means that's broken, etc. Yeah, it's very, I don't want to do it an injustice, and I'm not, so there's probably people going to be out there kicking and screaming going, that's not what it's all about, but everyone knows what I mean. I think you're absolutely right in relation to clinical safety officers, because if you're going to go down the route of this sort of like, making sure that people are audited and making sure that there's more stringent sort of like regulation in relation to this, and that there's regulatory bodies. I'm in agreement with you. You need to have notified bodies for 129 in exactly the same way as you have for medical device regulation and the ISO space as well. Couldn't agree more. How that happens, I'm sort of like a bit more sort of like, out there in respect to that. But CSOs, we need to professionalize the CSO role. Unfortunately, within the landscape, as we know, whether it's independent or working for health organizations, those working for health organizations vary from a band 5 right up to a band 8A, or 8A or 8B. It's just it's just so varied. And if you're looking at the expertise you're looking for, and also there should be a register for CSOs. Everyone should be on a register. People saying, but it'd be really hard to maintain. No, rubbish. I don't agree with that. People just making excuses now in relation to that. We've got ICSs, ICBs, you've got the regional level, you've got CNIO, CCIO roles. They should take a responsibility to make sure that those registers are maintained. They know who their CSOs are, and they will know who their CSOs are. And I'm even saying and putting it out there, I want to be regulated as well. We deliver CPD accredited training for CSOs. I want someone to come and have a look at that training and say to them, yeah, you're on the money, and that you can train people, etc., and stuff like that. We should have all of this in place, but we don't at the moment.
And I want to add, because obviously you have a lot more experience, especially working on DCB 160 and kind of engaging with trust, whereas we're far more on the private sector side. One thing I just want to highlight, there, from what I've seen, there are some activities which I think do a disservice to our own sector. So when I see individuals or companies basically playing to the tune for certain vendors, where they basically say, don't worry about the CSO. We can provide you a CSO, but it's basically a CSO in name only. That's not only not safe, it is just terrible from a patient safety perspective. And so for me, I think there needs to be a lot more transparency around what is an appropriate service, whether you're on the trust side or on the vendor side. But number two, I think we need to start attaching some liability to the CSO role. If you are putting your name down to product releases incident reviews, what have you. If you are the clinical signatory, you better be ready to stand up in a court of law if something goes wrong. You need to be willing to stand up in front of a regulator. And I think that very quickly will get rid of, shall we say, the people who view DCB 0129 and 0160 as a business opportunity rather than what it is, which, sure, there are business providers of it, but it's a patient safety compliance requirement. It's same with cybersecurity. Just so that I'm not targeting DCB 0129, there are companies that just go around and say, we'll get you through ISO 27001 really, really quickly. And then you'll have a certificate and you can show it to everyone how great you are. And then you'll be the same company that has the most catastrophic cyber attack a year later. It's not about the certificate or being able to say, we have that standard. It's about putting it in practice operationally so that, you know, things can still go wrong, but you can prove that we've done everything we can to protect patients, to protect workflows, to protect our systems. We really have done everything that we can. So I think, yeah, for me, I'm just calling a spade a spade. I don't think sometimes our own sector doesn't behave in the way we want others to behave, which can be problematic.
No, absolutely, and I think organisations need to stand by their convictions. If they're going to go down, you know, everyone needs to go down this route and this pathway, the regulatory pathway. But I think I'm going to sort of like challenge now as well. Do you feel that sometimes organisations take what seems to be the easier route, which we know isn't, because if you're going to do that and you're just going to take a load of templates and call it 27001 or 13485 or whatever you want to call it, you're asking for problems in relation to that if you don't embed that culture within your organisation. But it's not made easy for people, is it, in relation to how pricey that is as well? Because as we know, you know, regulation's not cheap if you're going out into the independent sector. We're both in that space. However, we are subject matter experts in what we do. And if you're going to go with an organisation that has years and years of experience, you'd like to think that you're going to get a good service. But as you've just alluded to, there are people out there that are saying, oh, do you know what? I'll go and do my one-day NHSE safety training, set up a website, and I'm a clinical safety officer. Come to me for my services. And they don't have a clue what even digital health is. They have no experience in relation to that. So sometimes I think do we make it difficult for ourselves, or is it made difficult for, you know, especially when I think the NHS as well don't necessarily, they advertise and say there's lots of grant funding avenues and opportunities for manufacturers out there. But from my experience, it's really difficult to get onto some of those frameworks.
I mean, again, I can't speak so much with engaging with the trust specifically. And of course, I deal more with the cyber side, but I will say this from what I've seen through my organization. We are always keen to see more clinicians become CSOs. Whether we're hiring people and saying, you don't have to have this background, but we will pay and support you to be trained in it and train you in our way of doing things, as well as getting all the appropriate courses and whatnot. So we need to have a clear way for people to become CSOs. That's really important. What is challenging, though, is understanding there's a difference between having a CSO, like having an ISO 27001 certificate, and implementing the requirements in practice. And unfortunately, like with everything, if you don't have the capability as an organization to do it internally, then you're going to have to do it externally with an external entity. And at that point, you have a choice to make. Are you doing this for marketing, or are you doing it to be appropriately compliant? The marketing, you will get found out relatively quickly, because the trusts are increasingly saying, we want to see your risk register. We want the name of your CSO. And DTAC has driven that to an extent. So you will get found out if you're doing it in this marketing masquerade kind of way. But if you're doing it properly, then you need a budget for it, and you need to be looking for a CSO who you're going to engage with regularly. And so that is important. I think sometimes people think this is, I think you've encountered this as much as me probably, or anyone who's a CSO who's been doing this for a while will have encountered this. You get that email or phone call where someone goes, we're about to deploy a technology and we've been told,
we need this.
We need this by the end of next week. And you kind of go, that's not the purpose of it. The whole point is, there's a reason in the DCB 129 standard, it says for the manufacturer, you should have had this a long time ago.
Yeah, totally.
So yeah, I do think it's not a straightforward standard to implement. And I want to be sympathetic to, the salesperson or the implementing person at a vendor who's just won a deal, but for whatever reason, not malicious, they weren't aware of the standard. And now they're going, is this all going to fall apart? What can I do about it? The problem is, who is going to fill that gap? And I do think it should be persons, entity that has experience of doing it.
Yeah, totally. And I do agree with you. And I think a message for the audience out there and anyone listening that is thinking of getting into digital health space, do your homework. Be prepared. And if that means that there's an upfront cost of you going to a consultancy, and this isn't me sort of plugging anyone, but there are people that can give you the right advice and guidance out there. And if anyone wants that, I mean, we're quite happy to sort of like signpost any sort of like, or point people in the right direction. And I know you would be as well, Saif, in relation to that. So maybe after this, we put our heads together and just, throw out some links or some sort of like some information. I'd be happy to do that for people. Now, I want to come back into, so we've gone off chatting about the regulations and what we feel should be done. We've hopefully put the world to rights on that. And who knows what's going to happen in the consultations. I'll be interesting. I think it's going to be an interesting 18 months. Being realistic, we're coming up to winter crisis, aren't we? And nothing's going to happen with these consultations until the new year in relation to that. But it'd be really interesting to see what happens in relation to those. And I'm hoping to be a part of that. So we'll see, and I'm sure I can give some updates about what I can talk about on the podcast as well. Let's come back to cybersecurity and that whole piece. And I want to talk about patient data. It's all about the data. We've got personal devices now that people use. Wasn't a concept, was it? However many years ago that we had, my phone's not around actually, but anything that we had, iPad, phone, tablet, everything, you've got information at your fingertips now. But that always used to be the clinician. The clinician had the power, didn't they? The clinician had that information, and the poor patient was sitting the other side, weren't they, at the mercy of the clinician. Now the tables have turned for all the right reasons, and that patients are now taking ownership of their own information. However, the patient doesn't sit and do mandated cybersecurity training and information security training and has probably even less awareness around what they should or should not be doing in relation to their information. What's your experiences in obviously having that sort of like, done a master's in cybersecurity, so you said it now, Saif, so I can lean on that for information from you. It's an interesting sort of like, what's the approach in relation to that, and what should people be doing, I suppose, when we're looking at the regulations and we're looking at risk assessing, etc., and stuff like that. What should we be mindful of, and what does that mean to us as a nation and also internationally when we're looking at cybersecurity?
You just asked the easy questions, don't you, Dean? No tough questions.
Sorry.
So, I mean, first and foremost, I don't distinguish between, should we say, the general public and people who work in the NHS or any other organization.
No.
I think the levels of maturity are relatively the same. And especially when I look at people, I used to be a clinician, but I look at friends of mine who are clinicians or consultants or GPs or what have you. their first and foremost focus is getting through their clinic, getting through their theater list, dealing with revalidation, dealing with their admin. They're not thinking about cybersecurity when they're doing their job. And if anything, anytime they do have to think about cybersecurity, it's a headache that's getting in the way. And that's a more cultural issue, with just philosophically with the issue of how cybersecurity is done. As a general statement, though, anytime you bring more users, more devices, more applications into the ecosystem, you are expanding the threat surface area. Anytime you increase the level of interoperability, the channels of communication through which data will flow, you're increasing the opportunity for an attacker to exploit one of those nodes or to spread within the system. So that in and of itself, forget the usability, by the way. I'm speaking from a purely security person's perspective. Yeah, interoperability is great, but from a security perspective, it's a nightmare. So if I was a cybercrime gang, if I was, shall we say, a group that may be affiliated with a nation state, this is great. This is fantastic. All of this just is giving me so many more options to disrupt the system. Whether that's ransomware attacks, whether that's data breaches, denial of service attacks, and the really even scarier stuff, which we've only started to see a little bit of, but I've written about it for some time. And I coined a name for this type of attack several years ago, actually. I called it the clinical integrity extortion attack, where you manipulate the integrity of data or scramble it, things of that nature. You know, the options start to increase. The options really start to increase. So, and just at a simplistic level, it's terrible from a security perspective, even though it's fantastic when it's working for a patient, from a clinical outcomes, patient experience perspective. But just, you know, I'll hand back to you to ask me more probing questions, but just at a superficial level, it's terrible from a security person's viewpoint.
Yeah, no, and it must be an absolute headache for sort of like, you know, because I know from personal experiences when I've done sort of like bank shifts at my local hospital, and you know, when you first walk in and you're exposed to that sort of like, you know, you're given a handheld device, etc., and stuff like that, and you know, I know at the back end, like people have to, you know, they have to be conscious of locking it down, that you can't upload sort of like, you know, that individual users can't upload apps, etc., and stuff like that. And we're in, and then if you take the patient, then you know we don't have any control over that. All we can do is put sort of like disclaimers and give as much information in relation to that to say be careful, and oh, by the way, so I've got my chart on my by Epic. I've got AirMid. I've got the NHS app. I've got my GP. I've got tons of apps on there, and it's just more and more avenues, isn't it? Or the more apps I've got, it's the more avenues for someone to come and sort of go, oh yeah, I can grab your information. And this is where sort of it's not just grabbing my information, but it's potentially a doorway into that application to then grab everybody's information in relation to that.
Well, we should get too distracted from the point. It's one thing to say, yeah, it's the patient or the person in the general public and the apps on their phone. We are struggling to secure the main networks and systems in the average trust, right? Yeah. And to secure staff and staff behavior. So for me, again, if I was the attacker, you know, phishing emails targeting NHS staff, still a fantastic way in. Just searching the web for internet-facing appliances that haven't been configured correctly, that give me a way into the system, fantastic way in. I mean, one of the things that we have started doing as an organization, this isn't a plug, it's just a thing, you know, to be aware of. We work a lot using intelligence-derived data. So we access platforms that are used by the likes of Europol, where they are looking at directly into the infrastructure of over 900 cybercrime gangs. So seeing that actual communications, what's on their servers and stuff like that. It's quite scary, but it's fascinating at the same time. And you know, there is some wild stuff in there, and there are NHS admin details all over the place. You can find them on GitHub, let alone in the threat actor infrastructure. Let's expand it further. When you talk about the threat surface, I'm not worried about the general public. I'm worried about the 1,000 suppliers connected to each individual NHS organization and applications, and how many of their credentials are on there. Because once they're out there, that means they're ready to be used for a cyber attack. So it is, we are struggling. We are struggling. I mean, and it's not just healthcare, but healthcare in particular is one of the top targeted, top exploited, top successfully hit sectors in all, you know, I'd call them relatively digitally mature nations. And it's getting worse and worse and worse. And it's a real struggle. And I think the age of just selling antivirus and other cybersecurity products, it's not good enough anymore. We need to train clinicians to know how to respond to events when they don't have access to their systems. This hardly ever happens as far as I'm concerned, at least to the level that I want it to be. But also we need to be more proactive in terms of using intelligence. That's why I always say the NHS needs to work as closely as possible with the likes of NCSC and GCHQ. And, you know, this needs to become a national security and public health issue as much as it is a technical one.
Yeah, because I think it's a difficult one. I mean, you know, the NHS is an easy target, isn't it? It's too easy. It's, you know, one of the biggest organisations in the country. As me and you know, nurses, doctors, physios, or all the sort of like admin staff, anyone that works in the NHS, they've all got busy jobs. They're all under a lot of stress at the moment. You know, resourcing is sort of, you know, an issue. And the ask of the individual person within the NHS is absolutely huge, which just makes it even easier for those attackers to, you know, you've got a stressed workforce that are being, you know, sort of, you know, pushed to the sort of like to the limits. All of a sudden they're sitting there, aren't they? All these attackers going, yeah, they're not going to pay attention to, you know, to their emails or those sort of things.
Well, think about it this way. Let's take a ransomware attack. The people who will get the most stressed are the people looking after the patients. And it's the people who are looking after the patients who will say to the departmental manager, whoever, say, you need to sort this out. I can't access anything. I can't look at bloods. I can't look at radiology. I can't do anything. We're either turning away patients or keeping them stable. It used to be that the cyber attackers didn't know any of this. They didn't get it. They didn't understand it. They would go fishing. And if they happened to hit a healthcare organization, it was kind of opportunistic and by luck. They now understand this, you know, what I call clinical pressure, the clinical urgency. But what's easier? If you target a hospital, for example, you still have to target a system. You don't just say, I've attacked the hospital necessarily. That's possible, but it's not what's becoming the most frequent way. You want to cause the biggest cyber attack in the easiest way. So what do? Find a mid-sized health IT supplier or network infrastructure supplier whose product is maybe cloud-based, software as a service that's being used by 30 trusts. Hit them, and if it's an important enough solution and suddenly 30 trusts can't use it, you're going to get the supplier to pay you a ransom. But it's because you're causing a clinical impact in the system. Let's look at it another way. Let's say you use that supplier there and you go, oh, if you're a bit more sophisticated, you go, oh, this supplier is deployed in a couple of these hospitals. Oh, those are big teaching hospitals. Let's see if we can get from this application into that entire system of those hospitals and shut down the whole thing. And that's one step further. And then if it's a sizable enough institution, you're gonna have problems. So that's why it's like with DCB on tonight. Cybersecurity is just as important for the biggest organizations, but it's really important for these small to mid-sized organizations who are getting traction in the NHS as well.
Yeah, no, absolutely. I'd like to change tack slightly. Last night I was sitting with my feet up reading your white paper on disinformation, and it was really interesting actually looking at sort of, what is, because I didn't know the difference between misinformation and disinformation, but I do now in relation to that. So and for anyone that doesn't know, like sort of like, the review of the paper done by yourself and there was two other contributors, wasn't there, in relation to that, probably many more as well, but you'll let us know shortly, in relation to sort of disinformation during COVID, which I was absolutely taken by. I just got sucked in, and sort of it was just really interesting looking at the mechanisms and how that happened. We were part of that from the outside looking in relation to Chris Whitty and sort of all those people giving you lots of this interesting information that was coming out, and lots of different agencies as well. And like I alluded to before, we're now a nation of social media, aren't we? We are a beast. We are slaves to the beast, aren't we, of social media? We all, in some way, shape or form, can't help it, can we? In relation to that, and also it aids us within our businesses and what we do. Taking that and examples that you've used from sort of like from COVID, and then applying that now to the whole digital health sort of like arena, it's quite scary, isn't it? Really, I think it is in respect to sort of disinformation and sort of potential hearsay and all this sort of stuff. Where are we sort of at in relation to that? What's the role of the healthcare professional? Because we keep talking about this and saying that clinicians need to be more aware and clinicians need to be more sort of like in counteracting disinformation in the digital era and where we're at.
So I just want to provide some context. So
yeah, please do. Please do.
As part of my activities as an advisor to the World Health Organization, I was asked to write 2 papers officially. One, conduct an analysis of the impact of ransomware during the pandemic. That was the first paper. That's out there as well. I collaborated with the likes of the UN Office of Counterterrorism, Interpol, UN Office on Drug and Crime, UN International Computing Center, UN International Telecommunications Union. It was big. And then the second one was on the impact of disinformation, specifically during COVID-19. For those that aren't aware, disinformation is when you knowingly create or spread false or mischaracterized information with the intent to cause harm. Harm can come in many forms, but the intent to cause harm. Misinformation is when you share something, it is false, but you didn't know it was false. You're sharing stuff that you thought was interesting or that supports a certain worldview that you have or wherever it may be. But there is no malicious intent involved.
Yeah.
The issue is, though, disinformation and misinformation sit on the same spectrum together. It's hard to tell sometimes where one begins and one ends. But because I, shall we say, specialize in understanding things that are done badly on purpose or maliciously, disinformation was something that I was asked to look at. Disinformation is its own beast. This is geopolitical involvement. This is criminal involvement. This has existed really for the better part of a couple of centuries. Now, it's been a huge theme in public health. I can point people towards books if they're interested, but you just have to look at disinformation during the HIV/AIDS in the 80s to the early 90s. The same playbook has been used by nation states for Ebola, monkeypox, SARS, COVID. Same playbook. Literally, sometimes it's the same propaganda or piece of disinformation, but they've just swapped the name of the disease out.
Just tweaked it, right? Yeah.
So it's not necessarily original, but if it's effective, it will be used.
Yeah, totally. I'd like.
Look, this is such a complex subject for the reason being, it's one thing to train clinicians and even public health agencies to be prepared to help the public deal with misinformation or the overwhelming onslaught of information, being able to pick through it and decipher what's legitimate and what's not. That's one thing. It's something else as a nation to prepare ourselves for another entity, which may be another nation state, manipulating your system and flooding it with false information purposely. And this is the thing, the sign of a good disinformation asset. Now I sound like someone who's someone who's an expert in this, but a good disinformation asset can be made up of up to 80% truth, and it's only about 10 to 20%. This is like a rule of thumb. That's actually the falsehood, because you hide it in this coat of truthfulness or facts that are accepted in order to get the lie or the disinformation through. So it is very, very complicated. And that in and of itself is a national security issue, because you're dealing with people's emotions and fears, and that leads to sometimes quite scary actions.
Are you seeing this coming into play though within sort of like training, etc.? Are there sort of examples of sort of misinformation, disinformation that are finding their way into sort of mandated training and onto courses, etc., to raise awareness in relation to this? Or is it too difficult to sort of
so just this year, my team developed the first disinformation training module for the World Health Organization. It was just published a month ago. It's free to access. Anyone can use it.
Okay.
It's on the website is OpenWHO if you look it up on Google, and it's there, so anyone can use it. So that's a big deal. It's the first time WHO has ever done anything on this in terms of an e-learning module. We developed it, so it's definitely starting to happen. And I've developed fact sheets for the World Health Organization and things of that nature, which are also getting updated and published, and Q&A. So it's happening. More needs to happen. It needs to be adopted at a national level. But again, I'm gonna say, Dean, we have so many issues and limited resources and limited bandwidth just within government, let alone at the individual organization level. My concern is someone at some point has to make a call and say, what are we focusing on from a safety and security perspective?
What are the priorities?
And ultimately, I'm not in government. No one's asked me to do any public inquiries or turn up to any committees, so I can't really offer an opinion on that. I can only share that I've worked in these two areas, which are, cybersecurity and kind of the world of disinformation and propaganda, and they're both scary issues.
Well, this is why it's great having these opportunities, Saif, and that one of the big reasons that I put the podcast together is to get information out there, is to raise awareness. What we'll do after this, if we sort of some of those links and some of that information, those fact sheets, if we can sort of we'll put that out there on the intro to this podcast episode to let people know that that's where they can find this information. Anything we can do to sort of to raise awareness will be is a bonus, isn't it, in relation to that? Right, AI.
Oh yeah.
Oh yeah. So artificial intelligence. It's out there. It's an absolute minefield.
Yep.
At the moment, causing all sorts of issues within healthcare. It's just, I think, again, I keep coming back to it. It's awareness, isn't it? It's people's perceptions. I mean, first and foremost, you go to the ground roots. What is AI? And people talking about, because there's so many different, isn't there? Sort of large language models, part of machine learning, generative AI, and you've got simple and complex algorithms in relation to that. All falls under that AI umbrella. So when we start looking at AI and in relation to data security, patient safety, can we use AI tools to improve? Now, there's a question for you. to improve patient safety and data security models? And you may have sort of like an opinion on that, or does it just complicate matters in relation to patient safety?
So the first thing, I want to take a step back and just
go
through a little bit on the regulatory viewpoint on all of this, as far as I perceive it. Okay, so one of the things we did very early on was we got people within our organization to go off and get trained in ISO 42001, which is the new ISO standard for AI, risk management AI. We thought just it will help our own work, whether it's DCB 129 or security, to have people trained in that, let alone doing work in it on behalf of our clients. But what's really interesting is if we just look at how it's being implemented. So the most popular area I'm seeing where AI is causing friction and complexity is the definition of, is AI in a lot of instances by default ending up as software as a medical device? Because informing clinical decision making, triaging, training, all this kind of thing. That's probably the most complex area right now. But you ask about cybersecurity. Well, in the EU, because most of the companies who are doing this are a little bit larger, so they are automatically in European markets or international markets. We've just had the transition to NIS2, which is a cybersecurity regulation, is the best way to look at it. That now includes as its kind of top tier, one of its top tier categories, medical device manufacturers. So they have to, they're being targeted. It's not just healthcare generally, it's medical device manufacturers. So that's interesting. Okay. So you've got an out and out cybersecurity regulation being applied to all nation states. They're transposing it into law, which has significant fines associated with it, significant requirements associated with it. You have that targeting medical device manufacturers. Let's flow this down. You have the EU AI Act, whereby medical devices, if that's where the application of AI is treated as a high-risk AI system. That's going to have its own penalties and requirements just to be able to go to market. So you have in NIS2, you have the EU AI Act. Let's now flow this back down, from a local perspective. You want to bring an AI, LLM, whatever it may be, and you want it to help clinicians. Well, if it's not administrative, you're already into that murky territory if it's going to have to do something vaguely clinical to assist the clinician. So what started off as this really nice idea as a little piece of software, a little module that can help the clinicians that we can bolt on to our bigger product, suddenly hits straight into medical device regulation applies, EU AI Act applies, NIS2 applies, all mandatory things. And you're asking yourself, do we really want to play in this space? And I think that's right now when we get some companies approach us just trying to decipher all of this, we lay it out a little bit like that, going, this is potentially your minefield, let alone DCB 129. Because then the question comes up is the one we were discussing before. Am I a medical device or am I a health IT product? Where do I sit in that? And quite frankly, if you want to do compliance properly, as far as I'm concerned, you go through them, you do the full house. Because they overlap a lot, frankly. I mean, it doesn't have to, be a catastrophic scenario of regulation. There's huge amounts of overlap. But that's actually the minefield you have to go through if you want to bring AI safely into the world of healthcare.
And I think it has other implications. I suppose people have to do their homework. They have to do their due diligence, and especially seeing that, lots of things we've talked about previously on this episode around, the whole thing, data itself, that whole sort of like, because we know with AI, garbage in, garbage out in relation to that. So if there's already upfront data security issues or data integrity issues that have been caused by potential cyber attacks or, security attacks that an organization is unaware of and is sort of trickling along, then that information is then being used in that AI module, then it's going to cause it could potentially cause.
No, that's a fantastic point, and that's what makes a company that is AI centric, shall we say, even more potentially concerning, because one, you just have the generic security threats they present just as a company, like any other company that wants to connect it to a health system. But then when it comes to what I described as those integrity attacks, it is a lot more sinister and punishing and significant to these types of companies because they are dependent on their data integrity even more than any other company. Yeah, like sure, if you're an EHR provider, you don't want electronic health records to be tampered with. But if I was being cynically said, someone might tamper with just one record. Or if they tamper with all the records, hopefully you can pick up on it quite soon because you're wondering, why is a female patient's, breast cancer results appearing for this gentleman, or there may be things that that can be flagged earlier. I'm not saying it would still be horrific, but I'm saying maybe it'd be easier to pick up on. Whereas if someone's tarnishing the integrity of the training data set, it may be a really significant amount of time before you pick up on certain hallucinations, certain patterns and whatnot. Or when it's too late. And some harm has started to happen already.
And I was just about to say, people could, and this only this only came to mind while we were chatting about this, is that you could have cyber attacks that are intentionally trying to diversify the bias in relation to that. Someone could be plowing information, like you say, into a training model that completely changes the whole outlook of an AI model.
The thing I always say is, just to be fair, is that you can come up with any cyber attack and it's feasible. And so I always say I want to be realistic. Cyber attackers are still lazy. They want to make minimum effort and get maximum bang for buck. So it's still, can I ransomware this? Is there a misconfiguration, a vulnerability, a phishing way in? And can I just lock everything down and send a message and say, pay me 10 Bitcoin, otherwise I'm going to keep locking stuff down. That's still what's going to happen. But when I used to talk about the integrity attacks, people used to say, stuff of fantasies or nightmares, shall we say. And then we saw about a year later, there was an attempted tampering with the chemical composition that went into the Florida water system in a treatment facility. And it was the technician who picked it up that the change happened. Now, we don't know who did that. It could be just someone experimenting. It could be just like a random person. But it showed that it's possible. And we've started to see on a year-by-year basis more and more examples of this. I wouldn't be surprised if at some point the right attacker at the right time with the right interests and incentives would go after major companies' data sets and poisoning.
No, absolutely. We've spoken about a lot, Saif, in relation to cybersecurity, data security, etc. I'd like us to sort of come back to whole strengthening of our governance and our approach moving forward in relation to not just cyber sort of like security and that whole piece, but regulation as a whole. How do you think sort of like the likes of NHS England, MHRA, CQC, all of these sort of like these bodies, what part do you think they've got to play in the next 18 months, 2 years in relation to trying to sort of like, because it seems that, we're out there, aren't we, sort of trying to bang that drum, trying to sort of like, advise and guide and saying, look, guys, things need to change. We need to do X, Y, and Z. Do you think anyone's listening, or what are the next steps in relation to us moving forward?
That's a multi-layered question.
Yeah, it is. Sorry.
Do I think anyone is listening? I don't know, is the answer to that question. I mean, I'll share this publicly. After the cyber attacks that happened in June, I wrote 2 emails, one to Wes Streeting and one to Peter Kyle, basically saying, this is my background, this is my expertise, this is what I believe is the situation in terms of what happened and why it's clinical consequences. And I basically said, I believe this is the time for a public inquiry. or at the very least, a health select committee intervention. I would be happy to discuss supporting both activities, or turning up and being, deposed in front of a health select committee, and they can ask me questions for however long they want. And I said similarly, there are other experts in our field who I'm sure would be happy to be involved with this. The first one, I received a letter in response from a minister responsible for acute care, which was good. It was a very long letter, but it basically asked me and said, please connect with leadership in NHS England in terms of security, and I did. But it's people I know and I've known for a long time, and we're on good terms anyway. So it was essentially, yes, we want your expertise. Do it through this path. It is a path I know, and I'm already involved, which is fine. I received that was through the West Street route, which I thought, no, that's pretty good. Someone read it and said, this needs to go to this person who's a minister, and they did something about it. Would I have wanted more? Of course I wanted more, but it was more than I was expecting. The second letter, that was the response I got from the Department of Science and Technology, was only last week. And it basically said, thank you for your email. We take cybersecurity seriously. I'm paraphrasing. We have a public consultation open on this. Here's the link if you'd like to provide your opinion. And I kind of thought to myself, I got a reply, but that wasn't really the point of my email. So is anyone listening? I think the right parts of the media are listening. There are some fantastic journalists who've asked me my opinions on several articles and these are really top journalists. The types of journalists that weren't interested so much, I would say, in healthcare and cybersecurity and patient safety before are now seeing this as an issue in the public interest and really deep diving into it. I think beyond that, it's really hard to say. I personally haven't seen evidence that people have listened to what I have to say necessarily. You may disagree. Others, at least I'm very prolific on LinkedIn. I get a lot of support through LinkedIn from people in our industry, which I'm really grateful for because it inspires me to keep putting content out about my opinions and viewpoints and solutions. But with the people with the budgets in government, I don't even know if they know I exist. What I find interesting, though, is I know that people in the security world, the law enforcement world, outside of the UK seem to know a lot more about me than people in the UK do, which is a bit weird given this is my home country. So I feel more influential outside of the UK than I am in the UK.
Inside the UK. And that seems such a shame, to be honest, Saif, in relation to that sort of like, internationally, people are sort of like sitting up and sort of like listening, potentially that and I'm not saying we aren't listening in relation to that, but I'm sure we can do more. I always find, from my perspective, that those in the independent sector we're not necessarily embraced. Sometimes you may find it different in the cybersecurity sort of world, but I know from the sort of like my expertise in clinical risk management, no one's coming out with open arms and saying Dean or Adrian or Lyndon or any of the other guys out there that are sort of like experts within that, or out to yourselves, we need your advice, we need your guidance in relation to like sort of the way forward in relation to that.
I'll say this thing. The reason it is different in cybersecurity is government and law enforcement agencies cannot function without the private sector, and they know that. And because they know that, they're a lot more willing to collaborate and say, for example, person X, who's been a 30-year expert in cybersecurity, but happens to work for this private sector company, we want to bring you in to sit on a working group or to chair a working group, because even if you gave us 30 years, we would never have someone with the same expertise as you. They just accept that. They know that that's how the world works when it comes to cybersecurity. And the same thing, they do the same thing with academia. Let's say, look, we know you're external to us, but we need you. And there's no point pretending that we don't. And they'll find a way to make it happen. And even in government, people can have their views on this, critics or otherwise, but at least NHS England has worked with the private sector on cybersecurity projects because they know
totally.
just some things that cannot be done otherwise.
Well, they have to, don't they? They have to. I don't think they've got a choice because, you know, that expertise is out there in the independent sector from a sort of data and a cybersecurity.
Well, but yeah, exactly. But to come to your point about what would happen in the next 18 months, you know, you've named people that, you know, we all know each other. From our side, it's, you know, Dr. Alex Graham, the second half of the AbedGraham Group.
Yeah, absolutely.
He is from our side the master expert in DCB 029 for the past decade. I mean, as far as I'm concerned, and I know a lot of people disagree with me on this, I think we actually need a new regulatory entity. Now, I don't mean that as in we need another Quango, people like use that phrase. I mean we need to take a person from NHS England, from the clinical safety team, a person from MHRA, a person from the ICO, a person from NCSC, a few people from us, the independent experts, and basically form a committee that is the regulatory oversight committee that's responsible for the standard, that's responsible for having a budget for maintaining a database. It could be a secure version of Excel if such a thing exists, but that has a responsibility for implementing the things we said, but that also can do things like enact an audit regime on an annual basis on a random selection. And they should have the authority to initiate the sending out of letters that say, you're a vendor that's now going into special measures. But the reason I think something like that would work is because decisions can be taken from there. But then someone can say, look, I think this is really an ICO issue. ICO needs to send a letter because of this issue. And the ICO representative will say, leave that with me. Here's the timeline. Our next meeting is in 2 weeks. I'm going to go and enact that. Or it may be an issue where we raise in the committee, we say, look, we need cyber to be discussed a lot more in the DCB 0129 and 0160 guidance. The clinical safety person from NHS England will go, I'm going to take that as an action.
Yeah.
But there's a committee that's holding everyone to account, but also holding the market to account. Yeah. And by the way, I'm saying this all off the top of my head. It's not perfect, but that's what I think over the next 18 months could be formed that would really accelerate dealing with a lot of issues.
But the thing is, we need to have these ideas so safe, don't we? And I've sort of like mentioned something sort of like similar. We need that. We need collaboration. I've gone on about it on LinkedIn for quite a while now. That sort of like between sort of, you know, NHS England, maybe it's something we can do through the BCS, you know, or we need somewhere that's going to, we need an organisation that's going to support that, and for us to like use that as a vehicle to be able to get something like this together, and maybe we can make that happen. I know I'm going to be making some sort of like, you know, I've got a face-to-face actually this afternoon with the BCS clinical safety team, so I'm definitely going to mention that there. Saif, it has been absolutely fantastic having you on board. I've thoroughly enjoyed this episode. We could carry on for a long time, I feel, most definitely. Now, before I let you go, I am going to just put you on the spot one more time. I do this with all the guests, and just ask you for the audience is, for everything that we've discussed in relation to the regulatory space, if there's one takeaway that you could sort of like say to the audience in relation to what we've discussed, what would that be?
2 things linked.
Yep.
Do it properly. Because when you do it properly, when you have to stand up in court because it's gone wrong, you can actually defend yourself. I'll just add to it. Not that it's been enforced for, you know, what we've discussed, but the Corporate Manslaughter Act exists for a reason, and it's been used in the NHS. So if you're the CEO of whether it's a trust or a technology company, there are repercussions when things go wrong, ultimately.
Yeah, totally. I couldn't agree more. And thank you ever so much for joining us for episode 15 of The Only Way is Ethics. Saif, thank you for your time. And to the audience out there, I hope you've enjoyed this episode, and please join us again for episode 16. You can find us on Spotify and YouTube, so please come and subscribe. And thank you once again, Saif.
Thank you very much. It's been a pleasure.